On behalf of the Department of Pathology, would like to extend a warm welcome to our respected Director Sir, our learned teachers, beloved colleagues, and intern doctors who have joined us here. Today's topic is the role of pathologists in the diagnosis of breast cancers. Now this is the time for our chairperson, Professor Dr. Nazma Parveen Ansari ma'am, and our honorable research person, Professor Dr. Mirza Hamidullah sir, to be chaired on the stage.
Assalamu alaikum. Respected teachers, in this fine morning, I welcome you all in our weekly scientific seminar. Today we will discuss about the role of pathologists in the diagnosis of breast cancer. We know breast cancer is the second most common cancer worldwide. That's why good knowledge is needed for screening, awareness, diagnosis and treatment. Our today's speaker is our sincere lecturer, Dr. Walijan Sharna. Now I am requesting Dr. Sharna to deliver her speech.
Honorable Chairperson, respected Director, teachers and my dear colleagues, Assalamu alaikum and a very good morning. I welcome all of you in today's clinical meeting in role of pathologist in the diagnosis of breast cancer. Carcinoma of the breast. Breast cancer is the second most common type of cancer worldwide. Approximately 2.3 million new cases were diagnosed each year, and among them, 1 in 3 afflicted die of disease. On the basis of histopathological and molecular characteristics, various subtypes of breast cancer exist. Treatment options based on these types and stage of cancer. Now, the natural history of breast cancer. Normal breast epithelium may show atypical breast hyperplasia, which undergoes maybe genetic alteration or epigenetic alteration that may cause ductal carcinoma in situ, invasive ductal carcinoma in situ. From then, metastasis may occur. Latest world cancer statistics shows in each year about 18.1 million new cancer cases were diagnosed. Among them, most of the cancer occurs in the Asia, that is 48.4%. Breast cancer ranked first in incidence in the year 2020. Incidence of breast cancer is mostly occurs in the Australia and New Zealand due to their lifestyle. Now, in 2024, Global Cancer Incidence and Death Statistics report shows breast cancer is the 4th most common cause of cancer death. According to National Breast Cancer Foundation, 1 in 8 women have a chance of invasive breast cancer during their lifetime. Now, in our country, the breast cancer patient mostly occur in the age group 31 to 40 years, while in the developed country, it occurs mostly after 40 years. Now, in our both college and hospital pathology, in the year 2023 and 2024 shows total number of FNAC was 660. Among them, FNAC of breast was 121, that is 18.33%. Now, the differential diagnosis of disease from breast FNAC, we can see here the fibroadenoma ranked first, that is 70.97%, and ductal carcinoma in situ is in second position, that is 19.35%. Histopathology of breast specimen done in the year 2023 and 24 shows total number was 80 and carcinoma of breast found 13, that is 16.25%. Now, breast cancer in men statistics. In 2024 in the USA, 2,800 new cases of invasive breast cancer was diagnosed. 530 US men die from breast cancer. 1 in 726 have lifetime risks of development. Black men with breast cancer have worse prognosis. Now, the causes of breast lump. It may be mastitis, that is acute mastitis, lymphocytic mastopathy, granulomatous mastitis, subareolar abscess, or benign cyst. Number 2, benign epithelial lesion, that may be proliferative breast disease without atypia, proliferative breast disease with atypia. Number 3, the neoplasm of the breast. In case of benign, that may be fibroadenoma or phylloids. Phylloids may be malignant or benign. And the second one is the malignant, that include carcinoma and sarcoma. Now the risk factors. First of all, more than 70% person have no risk factor. Risks are more in female gender, increasing age, germline mutation of high percentage, strong family history, personal history of breast cancer, and high breast density. Relative risk 2.1 to 4 in germline mutation of moderate percentage, high dose radiation to chest at young age, and family history in case of first degree relative. Relative risk 1.1 to 2 in early menarche, late menopause, late fast pregnancy, nulliparity, absence of breastfeeding, exogenous hormone therapy, postmenopausal obesity, physical inactivity, and high alcohol consumption. Now, the methods of assessing lump in the breast that include triple assessment in the diagnosis of breast cancer. Number 1, clinical history and physical examination, imaging including mammogram or ultrasound, FNAC and core biopsy. Clinical breast examination, it is usually performed by doctor or trained practitioner annually for women over 40 years. At least 3 years interval for women between 20 to 40 years, and more frequent examination for high-risk patients. Breast self-examination. When to do? Menstruating women 5 to 7 days after the beginning of menses, menopausal women same date each month, pregnant women same date each month. Perform breast self-examination at least once a month. Now the clinical history. We must inquire about the onset, duration, rate of growth, change in skin, nipple change and discharge. Chief complaints. Usually, painless breast lump is the most common mode of presentation. Others include changes in the nipple, which may be discharge, retraction, deviation or destruction, changes in the overlying skin, that is pewdy orange appearance. Pain may be present in case of advanced cases and in case of inflammatory carcinoma. Swelling in axilla present due to regional lymph node metastasis. Now the signs and symptoms of breast cancer. It may include pulled-in nipple, nipple discharge, armpit pain, dimpling, lumping or thickening, and the skin texture change, which include rash, change in the areolar area, and the pewdy orange appearance. Now the nipple changes. It may include discharge, deviation or destruction. If discharge is present, if there is blood, then it may be case of duct papilloma or carcinoma. Pus may present in case of inflammatory carcinoma. Deviation nipple present in carcinoma of breast nipples that move towards the lump. And destruction of nipple present in Paget's disease and fungating breast carcinoma. Here is the imaging studies. Bilateral diagnostic mammography shows malignant lesion which have highly radio-dense area with irregular margin, and the benign lesion shows a smooth and rounded border. Another image of mammogram shows soft tissue masses and microcalcification. Pathological evaluation. The presence or absence of carcinoma in a clinically suspicious or mammographically detected abnormality can only be reliably determined by histopathology. Biopsy remains the standard technique for diagnosing both palpable and non-palpable breast abnormalities. The available pathological techniques for the diagnosis of palpable breast masses are fine needle aspiration cytology, core cutting needle biopsy, and excisional biopsy. We can see here a fine needle aspiration technology. Here, a needle is used to draw sample fluid and tissue from a lump. Then Papa-Nicolau stain is done. After that, histopathology is done. Percutaneous core biopsy. Here, a small percutaneous incision is done. Then a core cutting biopsy gun is inserted to obtain tissue material. Then histopathology is done. Nowadays, it is the most common method for diagnosis of cancer. This is a picture showing the excisional biopsy. Now, how will you send the sample to the pathologist? It may include orientation and labeling, sample with preservatives, information that may be clinical diagnosis, pregnancy or lactation, any imaging report, any previous FNAC or core biopsy report, any treatment, chemotherapy or radiotherapy, and photograph if possible. Now, the types of breast carcinoma. Almost all breast malignancies are adenocarcinoma. Types are important for biologic and clinical association. It includes carcinoma in situ, which may be ductal carcinoma in situ or lobular carcinoma in situ. In the first picture, we can see the ductal carcinoma in situ, and the second picture shows lobular carcinoma in situ. There are many types of invasive or infiltrating carcinoma. Among them, infiltrating ductal carcinoma of no special type is the most common, and it is also known as classical ductal carcinoma. Others may include carcinoma with medullary pattern, lobular carcinoma, mucinous carcinoma, tubulous carcinoma, and etc. Another histological image of ductal carcinoma. Here we can see the pleomorphism, and there is infiltration. Histological image of ductal carcinoma. Now, the tumor grading. Bloom-Richardson histologic grading is the most commonly used tumor grading system. On the basis of tubule formation, nuclear size, and mitotic count, we have done the Nottingham combined histological grade that include well-differentiated grade 1, moderately differentiated grade 2, and poorly differentiated grade 3. Molecular classification of invasive breast cancer. On the basis of changes in DNA, messenger RNA, protein, and morphology, breast cancer are classified into 3 groups. Number A, nominal, that is ER positive and HER2 negative. Number B, that is HER2 positive, and C, triple negative breast cancer, where ER, TR, and HER2 all 3 are negative. So, molecular classification is done by immunohistochemistry. Nowadays, it is the mandatory routine test. It is the study of detecting protein by using specific antibodies visualized with brown chromosome. In the first picture, we can see a hematotoxin ursulin stain, and the second picture, the same slide is immunostain, that is ER positive. We can clearly see here the brown chromosome. This is a immunohistochemistry of HER2. We can see the membrane is stained with brown chromosome. Now, the HER2 immunohistochemistry. The first picture, we can see here no stain is done, so that is negative. In the second picture, we can see a few brown stain, that is also negative. Third picture shows some stain, that is equivocal. And the fourth picture, we can clearly see there is staining, so that is positive. In case of equivocal, we have done the fluorescence in situ hybridization, that is FISH. The first picture shows FISH negative and the second picture shows FISH positive. This is the comparison between three types of cancer. In case of luminal, the ER positive, PR is positive, but HER2 is negative. In case of HER2 positive, ER negative, PR negative, and HER2 is positive. In case of triple negative cancer, ER, PR, and HER2, all the three are negative. Now, the prognostic factors for breast cancer. Prognostic factors are important in counseling patients about the outcome. The major prognostic factors are distant metastasis, once present cure is unlikely, regional lymph nodes. The more the number of lymph node is involvement, prognosis is more worse. Tumor, that includes size, skin involvement, chest wall invasion. If the skin is involved or chest wall is invaded, then that is the prognosis is more worse. And histologic grade, survival less in higher grade. Expression of ER, PR, and HER2, survival is higher in luminal group and is lowest in triple negative group. No one should face breast cancer alone. The theme for Breast Cancer Awareness Month, October 2024 was No One Should Face Breast Cancer Alone. The theme highlights the importance of community support and access to care for patients and survivors. It also emphasized the power of collective action and the importance of early detection. Breast cancer death rates have slowly decreased due to increased awareness, better screening, early detection, and continually improving treatment options. Don't discard any tissue removed from the body, must submit for histopathology. Apparently innocent looking tissue may contain ugly behavior. Absent or incomplete clinical information in the requisition form is one of the most common problems faced by the histopathologist during reporting. Although screening and early detection are the point of focus, particularly in developing and poor countries, more researchers are needed to improve the prognosis of patients, those who are diagnosed at a later stage. Thank you all for participating in today's seminar with patients.
The floor is open for discussion.
First of all, I'd like to thank the Pathology Department and my sir and madam for presenting such an important topic related to breast cancer. My question is to the speaker. In case of sampling of core biopsy and excision biopsy, we can see the tumor, we can diagnose that cancer is present, but how much metastasis or local invasion is there, we cannot tell. Can we tell